Good morning, everyone. Today, our topic of discussion is dermatomyositis and polymyositis. Now, these are basically inflammatory myopathies in which there is inflammation to the muscles. So, um, polymyositis and dermatomyositis, they are more or less are the same conditions, but as you can see that in one in which is dermatomyositis, in that one there is some skin manifestations as well. So simply, you can say these are basically inflammatory muscle diseases. And when they are inflammatory muscle diseases, they are basically autoimmune conditions, or they are autoimmune diseases. So these are autoimmune diseases, these are inflammatory muscle diseases, and also you can say the important thing about them, about these, like the causes are not known. Okay, we don't know exactly what causes this thing. So as I told you, there are two, polymyositis and dermatomyositis. So they are characterized by inflammatory process affecting skeletal muscle. And when there is skin involvement, so it will be called as dermatomyositis. So they are the same conditions. They are rare, not so common. So now, what happens in these inflammatory myopathies is basically proximal muscle weakness with or without pain. Okay, so there is pain, there could be pain, there could be no pain. And basically the muscles, they get damaged by lymphocytic inflammatory process. So, or you can say non-suppurative lymphocytic inflammatory process. So as we know, like they are classified as, um, simply there are two kinds. Okay, there could be poly, there could be dermato. So one of the thing is like few of the things, or you can say important points, which these topics which are not important, you can say, when we are studying internal medicine. But as I told you, different exams like USMLE and CLAP, they ask such questions. So I can tell you few points which you can remember, which can help you uh, from MCQ's point of view. There is association with malignancy. This is very important point about this condition. So anyone, by the way, who present with dermatomyositis, what they do, they um, they screen the person for carcinomas, or simply you can say like anyone who have dermatomyositis or polymyositis, they have increased risk of malignancy as well. And basically it's dermatomyositis which is most commonly associated with malignancy than polymyositis. And also they are associated with other CTDs or connective tissue disorders, like Raynaud's phenomena and all these things. Okay. Um, Now, the important thing over here is one thing, which is also a condition, we call it as inclusion body myositis. Now, this one is again, you can say, a type of myositis, but again, like it affects mostly adult people. Males are affected more than females. Okay. The important point to remember about this condition is like there is vacuoles seen or vacuole cells on biopsy. Okay, this is the identification point of this one. Okay, so basically, like whenever we diagnose anyone with the polymyositis and dermatomyositis, so the treatment is we put them on steroids, and when someone is not responding on steroids, then we have to suspect inclusion body myositis. So you can say suspect in anyone who is not responding to treatment. So this is the important point about this one. Though this condition, like I'm not going in more detail, but on biopsy, like there is inclusion bodies, and that's why we call it as inclusion body myocytes, or what you can say the vacuole cells on biopsy. So they are the same thing. So now um, about the dermatomyositis and polymyositis. I'm going to wind up all these things in one, you can say one lecture, because they are small or they're short topics anyways. So now there are some features or clinical features which I'll be talking about these conditions, as well as um, you can say the etiology and pathophysiology. So etiology and pathophysiology um, is not known. Okay, this is like again which is not known about many other conditions. But what they know is like polymyositis. Okay, polymyositis is a CD8 cell mediated muscle necrosis, and it is found in adults, whereas dermatomyositis is B cell and CD4 immune complex mediated perifascicular vascular abnormalities. Like this is what is known about these conditions. Okay, and rest like much of the things are not known about these conditions, like how they are found, what is the pathophysiologies, and what kind of people. But yes, there is association with cancers, so that's an important point to remember. And dermatomyositis in particular, you can say it can affect the children as well. That is called as childhood or juvenile dermatomyositis. So now I will show this one. This is the classification criteria for polymyositis and dermatomyositis. You can see symmetrical proximal muscle weakness, typical involvement of the shoulder girdle and the hip girdle, and if there is elevated muscle enzyme, because of course there is inflammation in the muscles going on, so creatine kinase it gets raised because of muscle damage. Aldolase and LDH, which is present in almost every cell, AST and ALT, they all get raised, right? But CK is the most important one. Very important one is CK. Electromyographic changes, so there is short polyphasic motor units, high frequency repetitive discharge, and when they do muscle biopsy, they found segmental fiber necrosis, basophilic regeneration, perivascular inflammation in DMM, and endomysial inflammation in polymyositis. And in dermatomyositis, of course, there is skin involvement as well. So we say like anyone who have four of these things are present, okay, is definite diagnosis of PM or DMM, and if any three of these things are present, so it is probable diagnosis. Though it is not important to remember this classification criteria, because I have never seen this thing being asked in any MCQs or anything like this. So now about the clinical features, what happened, like the patients, they present with proximal muscle weakness. This is the most important thing to remember. So proximal muscle weakness means what? Like the shoulder muscles and the hip muscles, they become weak. So remember that if you will ask someone to get off from the chair without using the force of his hands, it's hard for them, because to get off from the chair, of course, like, or when you try to rise up from the chair, it is difficult to rise without using hands if the muscles around your hip are not working fine. So what we ask the patient, by the way, to uh, put their hands in front of the chest and then try to get up from the chair. So, or we ask the patient to comb the hairs, for example, because combing, again, they need proximal muscles, or climb the stairs. The power of the proximal muscles is very important in that one, right? So this is the important part which they have. So again, this one is, like, what is the difference between polymyositis and dermatomyositis? Antibodies, muscle biopsies, changes, cytotoxic CD8 4 cells, I told you. Here there is rash also, Gottron sign, so I will show you. Here it's written mechanic hands. Okay, and these are the proximal muscles, like they are showing you, they get weak. And also the neck muscles, it's difficult for them to lift their head off the pillow. So this is how these patients present. And whenever anyone have the skin involvement, remember, skin involvement are characteristics of what are the characteristic of dermatomyositis, right? And they are present more in females than males. So one of the things is called as Gottron papules. These are Gottron papules, G-O-T-T, like here it is written over here. Gottron sign or Gottron's papules. Papule is, of course, like something which we can feel, we can palpate. So this is pinkish color, flat-topped papules. They are present on the dorsal surface of interphalangeal joints. Okay, and Gottron sign is basically when they have smooth or scaly patches over the MCPs and IPs. Elbows, knees can also be involved. So this is how what is Gottron signs or Gottron's papules are. Okay, and one of the thing is called as heliotrope rash. Heliotrope rash, this one. Heliotrope rash. So remember, it is on the, you can see it like here. This is heliotrope rash. So again, this is villosious rash over the eyelids, usually with edema. In this one, of course, you cannot see edema, but it usually comes with edema. So very common signs. See, Gottron signs, Gottron papules. Okay. Heliotrope rash, and this is called as shawl sign. Shawl. The females, they take shawl. So because the rash distribution is like this, so we call it as shawl sign. So it is erythematous rash over the neck and upper chest and even shoulders, right? This is called as what? This is called as Shawl's sign. So I think, I don't know you can remember this thing or not, but I can write over here, Shawl's sign. Okay, so this one is Gottron papules or Gottron sign. This one is Shawl sign, and this one is heliotrope rash. Now, their hands look like mechanic hands. Dry, thick scales on palmar and lateral surface of the digits. See these scales. Okay. And they also have periungual erythema. You can see this. Redness, It is periungual erythema. Okay, so these are all the features are of this condition. Now, other clinical manifestations or other clinical features which can be present is cardiac involvement can be there, GIT or gastrointestinal involvement can be there, and pulmonary involvement can be there as well. Okay, whenever the cardiac involvement is there, so it could be anything like arrhythmias, congestive heart failure, conduction defects, ventricular hypertrophy, and even pericarditis. And whenever like the GID involvements, sign and symptoms can be there, so it could be dysphagia as well as reflux. And pulmonary, one of the pulmonary manifestation comes due to muscle weakness. You can say respiratory muscle weakness, as well as interstitial lung diseases can develop, and aspiration pneumonia. So these are the features of this thing. Now I told you guys, dermatomyositis most of the time associated with carcinomas. So anyone who present with any patient presenting with dermatomyositis, screen for cancer. Screen for, if it's a female, screen for breast cancer, lung cancer in both sexes, colon cancer, or in females also ovarian cancer. So screen for all these things, right? Or a screen of any one of these things. So it is associated with that. So simply, most of these patients, they are in their 40s, 50s, or 60s. And what happened, like they present with, some of the time, they present with systemic features as well, like, wait, I must add that thing here. Sorry. Systemic features like, you can say weight loss, fever, okay, fatigue. These kind of symptoms can be present in the patients, okay. So it could be presenting symptoms. Sometimes there are pharyngeal muscles also get involved, so that's why they have this dysphagia. Okay. So interstitial lung diseases occur in 30% of the patients, and it is strongly associated with JO1 antibodies. JO1 antibodies. Sorry. ILDs, whenever it is there, they present with JO1 antibodies. Okay, like whenever interstitial lung disease develops, so they have this antibody which is positive. So this is like the clinical features of these patients. Okay. So how we diagnose these patients? Okay, like how the diagnosis is done. So the diagnosis is, of course, like first of all, clinical features we will see. Okay. You again remember I told you the diagnostic things, and then you can talk about the blood workup, like you will go for CBC, now ESR CRP, ESR and CRP could be raised, as well as you will go for creatine kinase, CK, it will be raised, and you can go for antibodies like anti-nuclear antibodies. They can be there. Anti-JO1 antibodies can be checked, and they are basically present in dermatomyositis, right? There are many other antibodies like you can say MI2 or anti-SRP. So not all have this one positive, but of course, like they can help in diagnosis of this condition. This antibodies can be checked, can be seen. So this thing is important. So Now, yeah, like the important thing about this one to talk about is, of course, you can say the confirmatory diagnosis will be done on muscle biopsy. Okay, like they are going to talk about it, they are going to see like exactly what kind of inflammation going on, and as like I show you there, EMGs can be done, electromyography can be done. So actually electromyography, it shows a triad of features that is like that you have seen over here. Electromyography give polyphasic fibrillation. Okay, they give fibrillation potentials, polyphasic and short duration potentials. Okay, and repetitive potentials or repetitive discharge or high frequency repetitive discharges are there in these patients. But of course, we go for muscle biopsy. That's the most important test you must remember in this one. So we go for that, and of course, like this thing, and of course, as I told you, they ask questions like this, that you have a patient, and he have this, and this, and now you made a diagnosis of dermatomyositis. What will be your next step? So when they are asking question like this, so of course, like a patient who have a confirmed, you can say, who is a confirmed case of dermatomyositis, so my next step will be screen for malignancy. Okay, so for example, chest X-ray, CT scan, okay, things like this. So these kind of options, of course, or PET scanning, whatever like you are suspecting or like the patient is showing. And what is the treatment of these cases or these things? Myositis and polymyositis and dermatomyositis. Of course, now these patients, uh, they have what you can say, muscle problem and all this stuff. So of course, uh, the thing is painful or too disturbing because they have muscle weakness. So what they do, like they do best bed rest and uh, exercise programs are given to the patient. So this is like how they start, and basically, this thing is done by the physiotherapists. They tell them like what kind of physical exercises they can do, and the pharmacological treatment, because it's an inflammatory condition. So guys, what we can do, just one thing, is high dose uh, corticosteroids. Okay, because we have to decrease the inflammation in these patients. So we start them with a high dose corticosteroids. And the things will go same in rheumatology. Uh, if the patient is not responding either or cannot take corticosteroids because of the risk of side effects, or for example, someone who already have something and steroids are contraindicated them, then we can, or if that, for example, if the condition cannot be controlled by corticosteroids alone, so we can add immuno uh, suppressive drugs, of course. So immunosuppressive drugs, there are many, but like cyclophosphamide, azathioprine, methotrexate, cyclosporine, any drugs like this. And if someone have a very severe kind of condition which cannot be managed even by this thing, so remember intravenous immunoglobulins can be for severe conditions. Okay, severe conditions we can use this thing. So and for rash we can prescribe the patient prescribe hydroxychloroquine. Hydroxychloroquine. Now, rest is of course like uh, if you'll talk about management, so of course like what is the malignancy treat that. So remember, guys, oral corticosteroids are the mainstay of the treatment, and it is start with high dose of oral corticosteroids. Again, you can give them prednisolone, okay, and we start with a high dose and then we taper off the dose. This is how we taper off the steroids, anyways, in most of the conditions. If someone who is not responding on that, or someone who cannot take corticosteroids, then we can think about immunosuppressive drugs. Azathioprine, methotrexate are mostly the first choice, and cyclophosphamide or cyclosporin or other drugs are alternatives, right? So this is how we treat these patients. So I hope like you understand this condition. Not so hard, not so difficult. Okay, and there are some like completely typical features about these conditions. So that's all about this condition, guys. Thank you so much for listening.